Good afternoon, respected seniors, colleagues, and residents. Welcome to the CGR for Unit 1 today. So talking about pediatric Budd-Chiari, and we'll go through the clinical features, pathology, and then the radiology team will take over. Sanjeevni will discuss some issues in the ward that we face, and Mr. Yadav will tell us how he helps these children, and we'll discuss long-term outcomes, and then closing comments by Professor Sharma, who's seen this for a long time. So what is Budd-Chiari? Budd-Chiari is basically obstruction of the hepatic veins anywhere from the smaller hepatic veins right up to where the junction of the inferior cava opens into the right atrium, regardless of the cause of obstruction. Now, this does not include veno-occlusive disease and cardiac disorders. So it can be primary or secondary. Primary is when you have a thrombosis or a web in anywhere from the hepatic vein formation to the junction of the IVC with the right atrium. Or secondaries can be due to a tumor, an abscess, or a hematological malignancy. So where do we see Budd-Chiari? This is a map of publications of regions where which are published on Budd-Chiari. And as you can see, India and China and North America and parts of Europe are the hotspots where this is reported. Now, but this disease is not the same in these areas and these areas. If you look at the number of publications which have more than 10 patients in a series, then China has the most publications, followed by India, followed by these other countries. Briefly, in the 1840s, Budd described 3 cases post-mortem where he described phlebitis of the hepatic veins, and he thought this was caused by abscesses or alcoholic hepatitis. Chiari, who was working as a surgeon in Prague, about 50 years later, made a better description of what he thought at that time was syphilis causing phlebitis of the hepatic veins and causing ascites and death. Thereafter, we knew more and more about this disease, surprisingly from the same hospital. Thomson, Turnbull, and Parker all published from the same hospital, and Parker's paper was really the first modern landmark paper, and slowly it became to be accepted that there is some hematological issue ongoing in these patients. Now, this is first data from the Western world. At the same time, Nakamura from Japan started describing a different sort of Budd-Chiari, where the inferior vena cava was involved more. And then there were landmarks after Stahls did the first transplant. In 1976, the first transplant in Budd-Chiari, treatment with anticoagulation. And finally, in 1993, which was a revolutionary step, use of TIPS for the treatment of Budd-Chiari. So how does it present? There are 3 forms of presentation. It can present as an acute fulminant liver failure, is indistinguishable from other causes of liver failure with high ALT, AST. We haven't seen this presentation in our cohort. And then you have acute and subacute or chronic presentations. Acutely, the child presents with abdominal pain, ascites, a large liver, enzymes are a little bit higher, but doesn't have encephalopathy. And chronic just presents startingly with very significant ascites. Why does Budd-Chiari occur? Now, people have looked at all these inherited and acquired prothrombotic disorders in Budd-Chiari, and we did a small project through an intramural grant in 2016 to look at 45 kids who had Budd-Chiari, and a majority of them had low protein C, protein S levels. Some of them had had Leiden mutations, antithrombin 3 was low. Only one had a homozygous mutation for MTHFR. None of them had a JAK mutation. Now, if you total this up, you can say 43% have some defect, but the fallacy is that when you test for these proteins, the thrombosis itself causes a lowering of these proteins. Also, if you are using warfarin in these patients, that also affects this assay. So to say that, whereas in the West, when you say 50% of 60% have some abnormality, most of them have PNH or lupus or JAK mutation, which is a very definite predisposition to thrombosis. Again, important difference is involvement anatomy. In India, hepatic veins and IVC is more commonly involved, which is similar to Western literature, whereas in Japan, IVC is the more predominant form of involvement. So coming to our cohort, we had 79 patients over about 7 years, mean age of 8.5 years, and most of them were boys. About half of them were more than 10 years of age, 42%. And then 10% or less than 3 years, which was a very challenging subset for intervention. Most of them presented in this chronic sort of presentation, and very Few had acute presentation, none had fulminant presentation. Ascites was the most common presentation, along with pain abdomen with asymptomatic organomegaly. Few had jaundice. GI bleed was an important presentation in a lot of these children. And median age at start of symptoms was 7 years, with symptoms ranging from a month to 7 years. Now, this is the most striking finding you will see in Budd-Chiari. It's very striking ascites with sometimes pedal edema and these veins which are prominent, especially if the IVC is blocked. And the differential diagnosis is pericarditis or cardiomyopathy. But if you look at their LFTs in this cohort, the LFTs are very mildly deranged or not deranged at all, or hardly any jaundice. Even the highest jaundice was only 5. OTPT is almost normal. Protein albumin is preserved in most cases. No coagulopathy. Even the scores for liver disease are mild. So this is misleading. The LFT and the scores are misleading. What they present is with a very prominent ascites. Now I'll request Dr. Prasenjit to talk about the pathology in this etiology.
Thank you, Dr. Rohan. We have now a decent experience on the core needle biopsy, transjugular needle biopsy in Budd-Chiari syndrome. Today I am not presenting those data, but I will show you what happens in Budd-Chiari. As you have heard, that the obstruction can happen in the level of the smaller hepatic vein or larger hepatic vein, or the suprahepatic part of the inferior vena cava. What happens? We see there is a lot of organomegaly, actually hepatomegaly, and due to this obstruction, what happens if there is obstruction? The surrounding lobules, we see centrilobular hemorrhagic necrosis. So this what happens in the acute Budd-Chiari, and later they are replaced by fibrosis. So in the acute Budd-Chiari, what we see, like just not nutmeg liver, this is postmortem liver, just to show you. So rest of the liver in the periportal area, this is preserved, and this is the microscopy. You can see all these lobules, there is centrizonal hemorrhagic necrosis, but hardly there is any fibrosis. So this is acute Budd-Chiari syndrome. And if we talk about the central vein or hepatic vein, this is the normal, which is a very barely perceptible structure with no thickening of the wall. In Budd-Chiari, sometimes we see this type of thickening of the central vein with collagenization, and very rarely in needle biopsies we identify this type of obliterated hepatic vein. As you can see, this is totally thrombosed. And what happens if there is obstruction of the central hepatic vein? There will be marked dilatation and congestion of the sinusoids, and that compress on the adjacent hepatic cords, so that cords become atrophied. And exactly that we see. Now the hepatic cords are being replaced by the congested sinusoids, which are filled with this RBC cord. So this is often known as the RBC cord pattern, and in between the hepatic cords are totally compressed. So even the RBC can be seen below the space of the DC, and they are replacing the hepatic cords. And that can be very nicely interpreted here. This is Hep1 stain, just to show you. This is the central hemorrhagic necrosis. This is the central vein, and everything is very much dilated and congested, all sinusoids, and these are the compressed hepatocytes. Okay, so this is the very classical finding of acute Budd-Chiari. In addition, what we see, the dilated sinusoids also change their phenotype. Normally they are not CD34 positive, which is the marker of endothelial cells, but whenever we see this type of dilatation, they gain the character, they become CD34 positive, as well as we see early deposition of the factor 8 antigen just below in the space of the DC. This is the initiation of the fibrotic process. Okay. Now, if we talk about the chronic Budd-Chiari, sometimes very rarely we can identify a totally thrombosed central vein. But most importantly, this area of fibrosis, unlike the other viral hepatitis entities, we don't see any inflammatory cells, so we call them bland sclerosis. And you will see around the sinusoid, this fibrous process, they are creeping into the adjacent central vein. So this is the bland fibrosis in the centrizonal area with surrounding hepatocytes. Sometimes we can see there is recanalization of the thrombotic area. This is actually a thrombotic recanalized thrombi. And sometimes we can also see the hepatocytes can undergo metaplastic change, and bile ducts can appear in those central zone of fibrosis. So sometimes gradually this fibrotic process, they become more prominent and they join each other, and finally we can see this type of cirrhosis. So still we can identify this is chronic Budd-Chiari because there is non-hepatic pattern. There is no interface hepatitis, not much inflammation. One difference is that normally in viral hepatitis, the cirrhosis, the main pathology starts from the portal area. So fibrosis starts from the periportal area and they join each other, one portal tract with the other one. However, in case of hepatic venous outflow obstruction or Budd-Chiari, the pathology start from the central vein and fibrosis also start from the central vein, and one central vein then fibrosis join with the other one. Hence, this type of cirrhosis is also called the reverse lobulation cirrhosis. So this is the pathology what I just showed you in brief. So I will now invite Dr. Amit from radiology.
Good evening, everyone. So I will be discussing the radiological diagnosis in a case of Budd-Chiari syndrome. So regarding the various imaging modalities, ultrasound is the diagnostic modality of choice because of its high accuracy, which has been reported in the order of 95%. Other useful characters of ultrasound in pediatric population is there is no need for sedation, and it does not carry the radiation, ionizing radiation, which is associated with CT scan. Ultrasound can also be used for guidance of interventions and for post-intervention follow-up, as we will see in the images. The other cross-sectional modalities, that is CT and MRI, they have limited indications for pediatric Budd-Chiari syndrome diagnosis in cases of equivocal ultrasound findings or for characterization of the various hepatic nodules that may come up in a Budd-Chiari syndrome patient. CT and MRI may prove to be useful. Coming to the ultrasound images, so this is how the normal hepatic veins look like on an ultrasound. So this is the hepatic vein. These are the three hepatic veins, the right, middle, and the left hepatic veins draining into the IVC. So on ultrasound, we see it as thin-walled anechoic channels. These are anechoic, means they are totally black. And if we put on the color Doppler, we will see the flow in the hepatic veins, which is towards the IVC. And if we put on the spectral Doppler, we will see this pulsatile blood flow within the hepatic veins. This is because of the transmitted pulsations of the right atrium into the hepatic veins. In a case of Budd-Chiari syndrome, we can see a thrombosed hepatic vein, which can have multiple appearances. First, in this case, this is the hepatic vein which is showing echogenic lumen. There is an echogenic intraluminal thrombus instead of the entire black hepatic vein. So this is suggestive of a hepatic vein thrombosis. Another appearance can be of an ostial occlusion with the absence of any blood flow at this level. In case of chronic hepatic vein thrombosis, we can see this. We can see this chronic. The hepatic vein can be seen as a long echogenic cord-like structure instead of an anechoic lumen. Another etiology is for a discrete echogenic web lesion. So this is the IVC, and we can see this echogenic web within the lumen of the IVC causing the obstruction. The secondary changes which can occur to this hepatic vein or IVC obstruction can also be visualized on ultrasound in the form of multiple veno-venous collaterals. So these are the comma shaped. These are characteristically known as comma shaped veno-venous collaterals within the liver parenchyma. Because of the independent drainage of the chordate vein itself can become dilated. This is the chordate vein, and the criteria that has been used is the more than 3 mm of diameter of chordate vein is taken as to be enlarged. Because of the same reason, the chordate lobe can get enlarged disproportionately as compared to the rest of the liver. So this is the enlarged chordate lobe. Other findings of portal hypertension can be seen on an ultrasound in the form of ascites. Dilated portal vein can be seen. Splenomegaly can be seen. Ultrasound, we use ultrasound for follow-up of our patients after intervention. This is the stent, echogenic stent, which is seen on ultrasound, and we can see the good blood flow within the stent, suggestive of patent stent. Regarding other modalities, as I said, one of the indications is for the characterization of the nodules which can come up in the liver. So this is the ultrasound image showing multiple hypoechoic nodules within the liver. Another modality which can be used is the contrast enhanced ultrasound, which may give us more information about the characters of this nodule. So this is the B mode ultrasound image showing a hypoechoic nodule, and after we give the contrast and we follow the enhancement pattern of this nodule on the arterial phase, we can see the nodule is showing enhancement, but there is no washout which is seen in the delayed phases. So this characteristic enhancement of the nodule helps us to differentiate it from more malignant pathology, that is a hepatocellular carcinoma. Similarly, for MRI, these are the MRI images which show the nodule. These are the T2 weighted image which shows a T2 hypointense nodule which shows arterial phase enhancement, and there is the nodule, the enhancement persists on the delayed phase images as well. There is no washout. So we can more confidently characterize it as a benign nodule. On CT scan, other findings that can be seen is the heterogeneous contrast enhancement of the liver parenchyma, and we can use the multiplanar reconstruction images from the CT scan to better visualize the IVC. This is the IVC which shows this beak-like narrowing at the level of the suprahepatic IVC, and this is a dilated collateral vein which is seen draining into the IVC. In a minority of cases where we are not able to make a diagnosis, where there are equivocal findings on other modalities, venography may be used for the diagnosis. However, as Sir will describe, the venography is mostly used as a part of interventions nowadays. So this is the IVC venogram which is showing this beak-like narrowing in the suprahepatic IVC. Another case which is showing ostial occlusion of the right and the middle hepatic veins. So this is again suggestive of Budd-Chiari syndrome. Now I invite Dr. Madhusudan sir to talk about interventions.
So, good afternoon, everyone. Once we have made a diagnosis of pediatric Budd-Chiari syndrome on ultrasound, we need to plan the interventions. So, the intervention is planned based on the morphologic appearance of the hepatic veins which is occluded. So, like if we have membranous or ultra-short occlusion of the hepatic veins, like in this case, it's a very thin membrane, what you see here, which is occluding the middle and the left and the middle hepatic vein. So, in that case, we would plan a simple venoplasty. So, a balloon angioplasty is sufficient in this case. Then we have a range of 5 mm to 3 cm long lesions, as in this case. As in this case, we have a long length lesion of the right hepatic vein or of the middle hepatic vein. Both of them show a less than 3 cm long stenosis or occlusion. So in these cases, we would like to place a stent. And then once all the 3 hepatic veins are occluded, so there is no way of recanalizing these veins. So in that case, the only option is DIPS, direct intrahepatic portosystemic shunt. What are the approaches which we use? The most common approach what we use is a transjugular approach. We come through the interjugular vein, through the right atrium, and then try to negotiate the obstruction. There will usually be a small beak of the right hepatic vein or the middle hepatic vein which we are trying to recanalize. Once we wedge our needle into that beak, then we are able to poke across the obstruction to get into the patent part of the vein. Or we can, for IVCs, we almost always do use the transfemoral approach because it's easier to get. We have a long length of the landing zone to place our catheters and needles and to cross the obstruction. So this is a suprahepatic IVC which is showing occlusion there. And then the third option is to do a direct transhepatic approach. Sometimes it may be difficult for us to come through the transjugular route. The landing zone may not be much. In those situations, we can use the transhepatic approach, directly puncture the dilated hepatic vein and then put in our sheath and needle and then cross the obstruction. So these are the hardware which we use for our procedures. These are the long, typically adult length. The pediatric lengths are not available. So these are the adult length transjugular sheath and transjugular needle which is available. Then we have this micropuncture access set which is used for puncturing the hepatic vein directly when we are using the hepatic route, or we can use this to puncture, get access into the jugular vein as well. And then this is the stent graft. This is a covered stent which is used for tips. This is a self-expandable metallic stent. And then this is a balloon mounted stent, which again is the most commonly we use for hepatic vein stenting. And then we have this balloon catheter, which is used for venoplasty. So let me show you some examples. So this is a case of right hepatic vein occlusion, a short segment occlusion, which was planned for transjugular venoplasty. So this is the IVC gram, which shows a small beak. Which shows a small beak of right hepatic vein. So we wedged our sheath and needle, and then once we wedge, we have the needle which we can use to puncture the or poke through the obstruction and then get into the hepatic vein. So once we are in the hepatic vein, we can get a venogram, inject contrast, and see the length of the occlusions, and then we pass our balloon across. This is the short waist which we can see, and then after balloon angioplasty, we can see good flow of contrast immediately after the procedure. And then we can do on-table ultrasound as well. This is the procedure ultrasound which shows this membranous occlusion of the right hepatic vein, and then immediately after procedure we can see that the membrane is completely removed. Then we can use stenting depending upon, as I said, the length of the occlusion. As you can see, this is the right hepatic vein which has a long length of occlusion, around 2.5 centimeter occlusion. So in this case, we used a transjugular access, and then we this is the venogram which shows an occlusion here, and then we placed a stent here, and immediately after placing the stent, we can see good flow of contrast across the stent, and then the Doppler again on table immediately after the procedure shows good flow through the stent. Now, transhepatic, again, venoplasty or stenting is done again, as I said, based on the length of the occlusion. So in this case, we can see that sometimes the angle may be too acute for a transjugular puncture of the occluded portion. So in those situations, we use, typically this happens with middle or the left hepatic vein, which have more acute angle drainage with the IVC, suprahepatic IVC. And so here you can see we punctured the liver, punctured the hepatic vein transhepatically. We placed our sheath, and the venogram shows occlusion, and then we passed our balloon to do a venoplasty, and after the procedure we can see good flow across, and the Doppler also shows good flow within the vein. Then sometimes you might have to do a combined approach because in this case, again, we went transhepatically for the middle hepatic vein, and then there was complete occlusion. But as we continued to poke, we can see contrast leaking into the pericardial cavity. So once a false track forms, it becomes very difficult for us because the wire keeps on going into that false track. So we had to change our approach. We then came through the transjugular route, and then we used our needle to poke across. So in a combined approach, one advantage is that we have two lumens facing each other, and it's easy for us to be sure that where we need to puncture. So we know that this till this end of the sheath is the lumen, and then we know the direction in which we need to puncture. So it's easy for us. So we punctured it, and then we plastied this occlusion, and then we can see good flow across after the procedure. Similarly, for IVC, almost always we start with the transfemoral route. So this is the venogram showing occlusion of the suprahepatic IVC, and then this is the balloon. And then we almost always do a venoplasty for IVC, because most of the times, because of the high flow there, venoplasty is usually enough to maintain the patency once an angioplasty is done. So this is the Doppler after the procedure showing good flow across. Then again, a combined approach for IVC. Again, as I said, sometimes we keep poking, and then there may be contrast leak into the pericaval space. And again, going further through this approach may become difficult. So we have to come through the transjugular route, and then we can use this combined portion to directly puncture from above, and then we get our balloon across to do a plasty. So lastly, combined procedure, when sometimes you have a combination of hepatic vein as well as IVC occlusion. As in this case, we saw that the previous case had, we opened up IVC, and in the same case, we used the same transjugular route to go across the right hepatic vein. This was a long segment occlusion of the right hepatic vein, and then we placed a balloon mounted stent, and after placement of the stent, we could see good flow across. We had come across one patient who had presented with acute thrombosis of the hepatic vein. So this was the ultrasound picture showing acute thrombus within the hepatic vein. Although when the patient presented to us, he was already 1 month with the diagnosis of acute hepatic vein thrombosis. Usually thrombolysis is effective when we do it in the initial 2 weeks. So after that, the chances of recanalization becomes less, but we still went ahead and performed the thrombolysis. We first used the balloon catheter to macerate the thrombus, and by using balloon, we could see a web-like stenosis as well. There was a cause for the hepatic vein thrombosis to form, and then we used urokinase. This is the catheter, infusion catheter. We used urokinase for 48 hours, and then we could recanalize the hepatic vein partially. But again, after 6 months, the patient came with complete thrombosis of all the veins, and we had to do a TIPS for this patient. Now, lastly, now we are focused, till now I focused on recanalization of the hepatic vein. So that gives a physiological flow to the liver, outflow to the liver. But once this procedure recanalization is not possible for long segment occlusions of all the 3 veins, then what we can do is only decompress the portal hypertension feature. So this procedure is where, this DIPS is a procedure where we create a connection directly between the IVC and the right hepatic vein. Unlike TIPS, this is done in cirrhosis, where a connection is established between the right hepatic vein and the right portal vein. So as you can see in this image, the distance traversed here is shorter compared to a distance traversed in the DIPS patient in Budd-Chiari syndrome, where we create a channel between the suprahepatic IVC and the right hepatic vein. And again, because of the caudate lobe, this distance further increases. So that's the challenges we face when we do a DIPS procedure in Budd-Chiari syndrome. So this was a patient who had occlusion of all the 3 hepatic veins, and then so when we do DIPS, we use a lot of ultrasound. So you can see here under ultrasound guidance, this is the portal vein. So we can use ultrasound guidance to puncture the portal vein. Hence, the amount of fluoroscopy which we use becomes very much less. So once we have punctured, so we pass our wire, and then once we pass our wire, we pass our catheter and do a portogram. We can see this is the portal vein, right portal vein, left portal vein, and then we dilate the tract with balloon and then place our stents. So, and then this is after placement of the stents, we can see good flow from the portal vein to the right atrium. And then follow-up is done by ultrasound Doppler, and we, in a study, we used the elastography as well to see the success rate of the procedure. So this was one complicated case which I wanted to show. So this was a patient, a 6-year-old female who had a diffuse thrombotic disease, and she had thrombosis of the jugular as well as femoral veins, and we could not have we cannot do a standard TIPS, transjugular TIPS. So in this case, what we did was directly punctured. This is the left portal vein and this is the IVC. We punctured directly transhepatically, put in our needle across from the left hepatic vein to the IVC, and then passed our wire across. So this is the wire which has gone into the right atrium there. And then we also punctured the splenic vein. So through the transsplenic approach, and then so we passed our sheath across into the from the transsplenic into the splenic vein towards the portal vein, and then we dilated this tract. Once we dilated this tract, we could easily pass our wire across and then finally place our stent. So this is the portogram which we performed from the transsplenic route, and finally we place our stent, and then patient is on follow-up. The last week she had come and she is doing perfectly well. So this was an extreme case which we even published as well in JVIR recently. So complications, we have had only one major complication. So during the procedure itself, the patient bled, patient went into hypotension, although immediately. So this was the portogram which we performed after dilatation of the tract, because in this case, the part of the portal vein was extrahepatic, and once you dilate, immediately the blood starts leaking out, and that's what happened here. Patient went into hypotension, and then the contrast study shows the contrast leak, and immediately we placed the covered stent there to seal off the rent, and then finally the patient, at the time of procedure, patient went into hypotension, but he was revived and then he's doing well. Follow-up imaging, as Dr. Amit showed, we do ultrasound a lot, regularly follow up these patients. So immediately after the procedure, till the time patient is in the ward, usually on an average 1 week, the patient is, we do an ultrasound on day 1, day 3, and then just before discharge. Then after that, the protocol is to follow up the patient on the first month, and then every 3 months in the first year, and then every 6 months. So recurrence, again, the procedure steps are the same. If the patient comes back with recurrence, we either do a venoplasty or a stenting based on the anatomy and the appearance of the morphology of the lesion. So even for a DIPS, occlusion of the DIPS, we again do a plasty and then place an overlapping stent if that becomes necessary. So coming to IR data till August, so in the last 7 years, we have had 79 patients where we have performed 90 procedures. And most of the patients were male here. So there were 60 patients who had hepatic vein occlusion, 12 patients with hepatic vein and IVC occlusion, and then 7 patients who had only IVC occlusion. So these are the vessels which we had treated, the most common being the right hepatic vein, the middle hepatic vein, and the IVC. So procedure details, the most common procedure what we did was venoplasty. Because they are children, we tried to see if venoplasty alone is sufficient, and most of these patients had ultra short segment or a membranous kind of occlusion where plasty alone was sufficient based on the morphology. And then second most common was stenting, and 16 patients required DIPS procedure because none of the hepatic veins were visible. And then the most common approach again was the standard transjugular approach, and then the second most common was transhepatic approach, especially for middle hepatic vein. So procedure types, again, based on the different type of morphology, we perform either venoplasty or stenting. So this shows that most of the MHV lesions required stenting, whereas most of the RHV lesions and IVC required only venoplasty. So coming to the size of the stents which we used, most common because they are children, we try to use 8 mm stents or as 8 mm balloon catheters. And again, this depends on the size of the vessel which we were trying to treat or recanalize. and 8 was the standard one, which was possible in most of these patients. And then for IVC, 20 is the standard size because it's very capacious and it can allow 20 balloon to be dilated. And then for dips as well, 8 was the most common stent and covered stent which we used. And then radiation exposure in dips, we want to evaluate how much amount of radiation is, because dips is an intensive procedure, radiation intensive procedure. It takes a longer time to puncture the portal vein from the IVC. So we published this as well. So we calculated that in our study in 21 patients, the average fluoroscopy time was 23 minutes, and then the dose area product, this reflects the amount of radiation given to the child. So this was less compared to, this was adult radiation exposure paper which had come recently in 2016, which showed that the adult DAP was 129 and the fluoro time although was less, because this was for tips, not for dips. Then outcomes, technically, we have not failed in any of these procedures. Whatever procedure we have taken, we were able to recanalize that vein or perform a dips, and immediately post procedure we could get a good flow after the procedure. And then only one patient which I showed now had hypotension during the procedure and had a bleed, but still the patient was revived immediately. And then only minor complications were seen in 5 patients as minor bleed into the pericaval space or into the pericardial space. None had any significant problems at that time. So there were 28 patients, nearly 35% of the patients had recurrence after a mean time of 11 months. So of these 28 patients, we have performed another procedure, repeat procedure for them in 24 patients. 4 patients are waiting for the repeat procedure. And then again, the most common was the middle hepatic vein, which had recurrent lesion. And then again, venoplasty was the procedure which was performed previously for this. So venoplasty had higher chances of recurrence compared to stenting or dips. And repeat procedure again depended on the type of the morphology which we had. If the patient had already stented, then we did a venoplasty, balloon angioplasty of the stent. If the patient only had a stent earlier, then we placed a stent across to keep the this vessel patent. Then during follow-up, again, we performed a study where we could see if shear wave elastography of the liver did help in evaluating, assessing patients who present with the recurrence. And we also found that immediately this was the liver stiffness of the patients before the procedure, and immediately 24 hours after the procedure, there was significant reduction in the liver stiffness, which indicated that the congested portion of congestion, which is responsible for the increased liver stiffness, significantly reduced immediately after recanalization. So we found this, and we also found that this was useful in assessing recurrence as well in 9 patients of the 32 who had recurrence during 1 month and 3 months. So the liver stiffness began to increase. So once we found that the liver stiffness began to increase, we could suspect that probably the patient is going into obstruction again. So there was recurrence of the lesion. So we've tried to find out if any technical factors were associated with the increased chance of recurrence, but we did not find that whether it is hepatic vein involvement or whether a venoplasty. So all these procedure-wise or the vein-wise did not have any predictable role in the prediction of recurrence. And again, even the size of the stent or the balloon which we used did not help in prediction of recurrence. So recurrence occurred across all sizes of stents or balloons. Lastly, the patency rates, we could also evaluate primary patency rates, that is for the first procedure, and secondary patency rates for those patients who had a second procedure. We could find that most of the recurrences occurred in the initial 12 to 18 months. Then after that, the patency rates are more or less stable in the range of 70%. So that's what we found in our study. Now I call upon Dr. Professor Sanjay Sharma for discussing the challenges which we encounter in treating these patients.
Thank you, Madhu. In order to restore the hepatic venous outflow in these patients of Budd-Chiari syndrome, we've seen a spectrum of procedures that are available in the radiologist's armamentarium. But there are challenges, some of them met, some unmet. Now, inherently, these are complex vascular procedures done on small children with small anatomy, as small as 18 months of age and as low as 10 kg weight. And there is a steep learning curve to it, which we have got over in last many years. And which is why this needs a high risk consent almost in every patient. Now, the other challenge is the non-availability of a dedicated equipment and hardware, which is otherwise available for adults and maybe elsewhere in the world. In particular, I'm talking about two devices. One of them is a transjugular access set. The long metallic needle, if you had noted in the procedures that Dr. Madhu had shown you, that long needle which we use to access the portal vein from the neck, that is almost about 40 centimeters, and a child is not very long either. So, I mean, we are almost adapting adult hardware to suit the child's need, which is not appropriate actually. The other thing is that if you had noted, the procedure of direct intrahepatic portosystemic shunting, also known as DIPS, the shunt is created from the cava, from the suprahepatic cava along the liver and down to the portal vein. So there is a portion of a shunt which is inside the liver, which is the inside the liver, and a portion above and below which is open. Now, with time, what happens is that these patients with a stent in place, the stent may get narrowed, especially in the region where it's inside the liver. That is because of the neointimal hyperplasia that occurs over time. In order to circumvent this problem, a company called Gore has come out with a Viator stent, which has one single stent with a open portion, a covered portion, which is inside the liver, and an open portion again at the bottom. This is not available in India. So we end up using two stents instead of one single stent, a covered stent inside the liver and an open stent, which is like a double stent within a stent across it in order to keep the flow going. Then metallic stent, the use of metallic stents in young children is inherently a controversial thing, which many people argue that with time, the child's dimensions would outgrow that of a stent. So many people may not want to use this in the first place, which is what is our strategy also. We try and do angioplasty as far as possible in the beginning and use stents and dips only if required. And hopefully in times to come, we may see bioabsorbable or biodegradable stents. Until that time, we continue to use what we are using. And there are other miscellaneous challenges. For example, the radiation causes much more damage to children as compared to adults. So which is why now we have adapted to use ultrasound in preference to fluoroscopy as far as possible. Not just before, but intra-procedural also, in order to visualize hepatic vein and poke the portal vein, and every small single step is done by ultrasound specially. This is all in with the aim to save radiation. Then obviously every single child gets done under general anesthesia, thanks to the anesthesia department, and they all need ICU care in post-procedure period. There is a bed shortage, I know, we are all aware, which is why we end up doing only one case in a week, and there are always a couple of cases lined up in waiting. And this is an expensive procedure which typically occurs in poor patients. I am yet to see a very affluent patient with a child with a Budd-Chiari syndrome for some reason, I don't know. And there are obviously some difficulties in follow-up. These children generally come from far-flung areas, and they are poor, probably low in awareness, and which is why they have a lower compliance to drugs also, which are normally given to them in form of warfarin to maintain the INR. So I think with this, I now invite Dr. Sanjeevani from Pediatrics to take over.
Thank you, sir. I will briefly discuss a few complications that we've seen in the ward and the patients that we've managed. So post-procedure, when these patients come back, we monitor them till the effect of anesthesia wears off and continue peri-procedural antibiotics. Then we start them on low molecular weight heparin, and which is gradually switched to oral warfarin with a target INR of 2 to 3. And a check ultrasound with Doppler is performed, as is already mentioned. I would like to discuss a few cases that we've seen recently. First one is Master M, who presented with the typical complaints of abdominal distension, mild jaundice, and melena. He was diagnosed to have Budd-Chiari syndrome with the help of ultrasound Doppler. He had a stomy course with us. He underwent multiple large volume paracentesis, AVL was done for his high-grade varices, and then TIPS was planned for him, and it was done with high-risk consent in view of his poor general condition. Post-procedure, the child was managed in ward. On day 4 after the procedure, he started developing hepatic encephalopathy, for which initially medical management was started. As the encephalopathy worsened, he was ventilated and subsequently shifted to ICU. During ICU stay, he was also started on other medical management such as IV and L-ornithine and aspartate. And after that, we noticed that the ammonia levels were gradually climbing and they were not responding to our medical management. So we initiated continuous renal replacement therapy for the hyperammonemia. This is one of the indications of non-renal indications of initiating CRRT, which is followed by multiple sessions of sustained low efficiency daily dialysis. The plan was to monitor the patient, and if the medical management failed, we had planned for a shunt reduction. The patient had a 10 mm stent in situ. We had planned to decrease the size if he did not respond. But on further course, he would remain ventilated for a total of 10 days, but there was gradual improvement in sensorium, and the ascites also gradually improved. He was extubated, and at discharge, he did not have any encephalopathy. There was reduced resolution of ascites, had stable hemoglobin and better nutritional status, and was discharged. So we have seen that there are some risk factors that can be attributed in certain patients, where we can predict that these patients might have a higher risk of developing post-shunt encephalopathy, seen to correlate with higher MELD scores, having a history of prior encephalopathy prior to the procedure, a low gradient across the portal vein and the hepatic vein post-procedure, having generalized malnutrition, and even proton pump inhibitor use prior to the procedure. So we have seen that there is the importance of a careful patient selection, a non-renal indication of using CRRT, and that the cross-sectional shunt volume or area, they are independent risk predictors of HE, and the management was as described. The other case that I wanted to discuss is of a small child. She was 1.5 years old. She presented to us in July 2022 with progressive ascites. There was history of multiple large volume paracentesis, and CT done outside revealed non-visualization of hepatic veins, and a diagnosis was confirmed when she presented to us. A TIPS procedure was done on 5th, but she developed a stent block post-procedure day 4, and a revision TIPS was done on 12th. Post-procedure, the interesting thing was that the child, she did have fever initially, and she had elevated lactate levels compared to her baseline lactates of 2 and 1.8. And these hemodynamic changes, apart from lactate, she was also seen to have elevation in her heart rates. And these hemodynamic changes were seen to be persistent despite her treatment of sepsis and the child being otherwise stable. So there are certain hemodynamic adaptations which occur after a patient undergoes a portosystemic shunt. These values are derived from adult cirrhotic patients, but we could probably extrapolate for understanding. There is seen to be an elevation. These changes probably occur because of the large amount of blood that is shunted from the portal to the systemic circulation, and so there will be increase in the venous return and right-sided atrial pressures. So there seem to be immediately post TIPS, we can see that the mean arterial pressure has risen, the cardiac index has risen. There is also postulated that some vasodilatory factors from the gut are also transferred to the systemic circulation, due to which there is a decrease in the systemic vascular resistance. And these changes are seen to be persistent. They had a follow-up of around 2 months, and these changes were seen to be persistent even after 2 months of follow-up. So what we've learned from this case is that the hemodynamic changes are suggestive of a hyperdynamic circulatory state with elevated central venous pressures, right atrial pressures, elevated cardiac output and cardiac index, and a decrease in systemic vascular resistance. These effects in various studies have been shown to last even up to a year. This child is currently under follow-up, and we'll have to see how she behaves as we monitor her. I would like to invite Mr. Yadav to discuss about the financial assistance that we provide to these patients.
आप लोगों को नमस्कार। 79 पेशेंट्स को बड-चियारी सिंड्रोम के पेशेंट्स को हमने प्रोसीजर कराया। उसमें हमने 64 पेशेंट्स को फाइनेंशियल सपोर्ट हमने दिया है, और प्रोसीजर में जो डिवाइसेस की जो कॉस्ट होती है वो 65,000 से लेके 1.85 लाख तक होती है। और जो हमने ये पेशेंट को मदद की है वो सरकारी हॉस्पिटल में जो ब्रॉडर गाइडलाइंस है उस गाइडलाइंस के तहत जो पुअर पेशेंट है उनको मेडिकेशन, सर्जिकल आइटम और कंज्यूमर आइटम्स फ्री ऑफ कॉस्ट प्रोवाइड करने की प्रोसीजर है। तो हमारे यहाँ वार्ड में मैकेनिज्म ये है कि एक प्रोफार्मा होता है जिसको प्रोफार्मा फॉर रिक्विजिशन ऑफ मेडिसिन, सर्जिकल आइटम्स और कंज्यूमर आइटम्स बोलते हैं। वो परफॉर्मा को जो रेजिडेंट्स हैं, डॉक्टर्स हैं, वो फिलअप करते हैं, पेशेंट्स को सारे पार्टिकुलर्स भरते हैं और पार्टिकुलर्स भरने के बाद उनके जो भी सर्जिकल आइटम्स की रिक्वायरमेंट होती है उसके आइटम्स को लिखते हैं। इसके बाद जो है उसको इकोनॉमिक असेसमेंट और एवेल्युएशन के लिए मेरे पास आते हैं, MSSO के पास। हम उसको इनकम सर्टिफिकेट और BPL कार्ड के बेसिस पे असेसमेंट और एवेल्युएट करते हैं। अगर वो पुअर पाया जाता है पेशेंट तो हम उसे ऑफिसर इंचार्ज जो मेडिकल स्टोर के होते हैं उनको पास भेजते हैं। फिर वो जो है उनकी अपनी असेसमेंट और एवेल्युएशन होते हैं और फिर उस परफॉर्मा पे प्लेज इशू करके वो रिकमेंड कर देते हैं। फिर वो परफॉर्मा सिस्टर इंचार्ज के पास आती है और वो सिस्टर इंचार्ज उनको ऑनलाइन इंडेंट करते हैं। अगर लोकल परचेज में होता है तो लोकल परचेज के इंडेंट करते हैं और फिर नेक्स्ट डे जो है वो सारे डिवाइसेज जो प्रोसीजर के लिए रिक्वायर्ड होते हैं वो प्रोक्योर करते हैं पुअर पेशेंट के लिए। तो हमने 64 पेशेंट को हमने सपोर्ट किया है। थैंक यू।
Thank you. I'll just briefly finish with what was the long-term outcome. So this is the number of cases, not the number of procedures, because these are all new cases and we are doing new cases as well as re-procedures. So as you see, increasing number of cases. On the pandemic, we had a dip, but this year again we've done a few cases. And the median wait time is around 3 months for a procedure. This is by the time you arrange everything. Of course, this kid, 72 months, we didn't make him wait 72 months. He went home, didn't want the procedure, came back. So 79 cases. So the procedure done initially had a complication rate of 10%, which included hyperammonemia and encephalopathy, sepsis, pulmonary edema, hypotension. About 33% required a re-intervention, again complication rate of 12%. Encephalopathy, the child with sepsis died, which again re-intervention rate of 12% in these 26 cases. And then one case has had 4 procedures. The complication rate from warfarin is, as reported elsewhere, is about 8%. One of this was a major subdural bleed. So Dr. Madhu was talking about the venous patency. So that is a radiological outcome. For us, an outcome is clinical response. So about 80% of these children show clinical response from a few days to a few weeks. Ascites responds, portal hypertension improves. But about 10% do not show response and 8% show partial response. So when we were planning this CGR, we made an effort to call these patients again, those who were not following in the OPD. So around 33% we were not able to reach. They had a median follow-up of 6 months and we don't know what happened to them after that. So about 70% we have been in touch in the last 3 months and about 70% are asymptomatic. 10 have died, which is a mortality rate of among this of about 20%. And the reason for death was progressive liver disease. That is, despite putting a stent, the liver disease was severe enough that it did not reverse and they had complications of cirrhosis. 2 of them had a blocked stent, had GI bleed, worsening liver disease. Interestingly, one child developed hepatocellular carcinoma. This is well reported in adults, and that's what Amit was talking about, looking at these nodules on imaging, that whether it is HCC or not. So this is a predisposing factor for hepatocellular carcinoma also. And 2 deaths were unrelated. If you look at the survival analysis, the outcome is death. So it's around 75% in this large series. Now, if you compare it to, this is the largest series in the world published from this hospital in adults. It's about 700 cases. So similar outcomes, about 70 to 80% survival. If you look at other literature on Budd-Chiari from India and worldwide, if you look at interventions, so this is starting in 2010, 11 interventions, 25, 24. The ages were a little bit older. Follow-up was not that good. And increasingly, this is the largest series, 55 interventions. And then again, decent follow-up, patency rate of 82% at 5 years, but they had a lot of dropout, lot of censoring in that outcome. So this is by large the largest experience in the world, and I think we can add about 15, 20 cases to this that we have to still analyze. And the follow-up was decent, 70% follow-up of at least 3 to 4 years, and the clinical response was good, and we've learned a lot as we have gone on this journey. So just to summarize, this is an important cause of liver disease in children. It requires expert multidisciplinary care. You need an excellent IR team. You need your colleagues in the intensive care, nephrology, other teams. And you also need financial support because the therapy costs money. And this is a big experience. We'll analyze it more before we write it up. And I'll just request Professor Sharma, because he's seen this for several decades now, to conclude this presentation.
Thanks, Rohan. Our fascination with the pediatric, particularly a pediatric Budd-Chiari, goes back to almost 2000, year 2000. This was partly because of the experience that we gained from the adult Budd-Chiari syndrome, and also we realized that all children who come to the OPD and labeled as a chronic liver disease, not all have a CLD in that true sense. Some of them have a hepatic venous obstruction, IVC obstruction, which are all lumped together. So this was a subset in which could actually be helped by recanalizing procedures. That's how we all started. And I can recall in 2007, we presented a data of 29 patients of pediatric Budd-Chiari in the Radiology Society of North America, of successful patients done. That was more of a technical and lacked a long-term follow-up. But after that, I think Dr. Madhu joined and Dr. Rohan joined. They've made a real difference, and that's where we are now. We're documenting everything now in a nice manner. And I also remember that hepatic venous stenosis, for example, we used to always recanalize with transhepatic route, and the IVC almost always with the transfemoral route. And there were a subset of patients in whom the veins were not repairable, not recanalizable. Those patients we did not touch, and there was about a third of these patients, they went over to pediatric surgery. Dr. Sandeep Agarwal will remember doing shunt surgeries for them, which have drastically come down. The distal spleen preserving Warren's shunt, which used to be like a surgery for pediatric surgeon to do commonly at one time, now has all been replaced by a percutaneous procedure, which is like our dips. So we are doing percutaneously what earlier used to be done surgically. We used to always keep the pediatric surgeons on cover, I remember, for the fear of causing a problem or perforating a vessel. We at least in the minds we used to have that there is something as a backup. But then never we got to we actually needed a help. So now we've even forgotten that to take a pediatric surgery help, not to say anything, but we know that since we are working in an institute, we always have a pediatric surgery colleagues, as a support to us. And now, over these years, it's now almost become interventional radiological procedure and a service actually to the hospital. And all residents and fellows are they all involved as a routine procedure, which we have struggled over years to bring it down to this level. And I'm happy and proud to say this. And if there are any questions, we'll be happy to take. And I think it's hybrid, so anybody offline also might want to comment or
probably work. I think there is clearly a referral bias because since our game, our unit always has few patients in the care and you have to do the opposite on the no matter the question, now there is nothing about disease. Still in certain parts of the world.
We know occlusal disease is more in the context of and that is not taken in the definition of Budd-Chiari.
And Budd-Chiari, I would say, is two diseases. One that is seen the best. Most of them have a definite genetic thrombotic disorder or condition, and they have more of a, they have mostly purely hepatic venous thrombosis. What we see is a spectrum of vascular disease where we have portal vein thrombosis also, which is common, and hepatic venous IVC thrombosis is also common. Maybe we have been talking about this for a century, whether there is some phlebitis that is occurring through the gut, whether it is microbiota or it is infection. Something is inciting a phlebitis in the hepatic vein and IVC, where there is no underlying, in the majority of them, there is no definite thrombosis.
The numbers you know that we see, as you said, it's essentially a disease of poor. So there has to be something in it that's
Environmental.
environmental for us. We should have a look, through pathology,
Research on the etiology has not been specific for our Budd-Chiari. Till now, we only put outcomes, but nobody wanted to buy this.
But most of the diseases reported from India, the epidemiological work is in order.
It's basically nothing.
That used to be toxins before.
Toxins and very commonly seen. We can't